over the next half hour or so, I'm going to answer some of the questions which were submitted offline before this webinar over the past several weeks. I'm also going to try to give you some updates, if time allows, of things I've learned from the recent Academy meeting, neurology meeting, which is a virtual conference. Okay. Okay. So first question was, does sleepwalking increase one's risk for Parkinson's? So we heard from, we already heard from Dr. Patel the difference between parasomnia, which includes sleepwalking and sleep talking and REM behavior disorder. So if somebody has a history of sleepwalking, does that predispose one to Parkinson's or one of these synucleinopathies? And before I read this article and did some researches, I didn't know the answer myself. My initial knee-jerk response was no, when in fact there was a study of 25,000 plus men with a mean age of 76 years of age, and they found out that sleepwalking without REM behavior disorder is associated with the greater risk of Parkinson's in the order of about 4 times. Of course, this is not as big a risk as REM behavior disorder, which makes patients a greater risk for Parkinson's or synucleinopathy. But if you have both sleepwalking and REM behavior disorder, then the risks are even greater. So I guess if you've been sleepwalking, which is something that usually starts at an earlier age, and then you develop REM behavior disorder when you get older, I guess that's a double whammy. But sleepwalking by itself carries a risk for Parkinson's, about 4-fold increased risk for Parkinson's. Okay, this I missed in the other webinar since we lost time to answer the COVID questions. I've been receiving these questions almost daily in my office. So I'm going to answer the COVID questions, which I get asked about almost every day. So if I have Parkinson's, am I more susceptible to COVID? And the answer is no. So Parkinson's patients are not immunocompromised. So they're not more susceptible than the general population of the same age to develop or be infected with COVID. However, if I have Parkinson's and get infected with COVID-19, will I have the same clinical course as somebody my age without Parkinson's? And the answer is no. You are at more risk for developing complications, especially pulmonary complications. So patients with Parkinson's have reduced lung capacity. They have some restrictions in their breathing muscles. They have difficulty expectorating their phlegm and their saliva. So they're just more prone to pulmonary complications. And then if you have ups and downs and you're more feeble and you're elderly, ups and downs with your medications on and off periods, that also affects your breathing capacity and ability to expectorate and cough up the junk. And then they also found out that the risks for pneumonia are higher, as well as need for oxygen and hospitalization are higher if you have longer duration of Parkinson's. So for instance, for patients with Parkinson's with more than 9 years duration, the risk is about 44%, whereas for patients with duration of disease of 9 years or less, the risk is much less at 14%, but it's not negligible. It's certainly higher than the normal elderly population without Parkinson's, but at the same time, the longer the disease duration, the higher the chances that you'll be slammed if you end up in the ICU or in the hospital with a pneumonia, and that your chances for being intubated and being in the ICU and having a prolonged stay will be higher the longer the duration of Parkinson's. And in fact, they found that the risk of a fatal outcome from COVID is around 30% greater if you have Parkinson's disease. So and this is mainly due to the pulmonary complications from COVID. Okay, if I have Parkinson's, how do I know that I have contracted COVID if I do not develop cough or fever? And this is a good question because um, the the elderly population may not manifest with the classic symptoms of COVID, pneumonia, and many of them may have non-specific symptoms, especially in the beginning, and a number of them don't even have a cough or a fever. And one of the things we are told to be on the lookout for whenever one suspects COVID, whether you're elderly or young, is to look for loss of sense of smell and taste. But is that something reliable in the Parkinson's population? And the answer is no, because to start with, the loss of sense of smell, and Dr. Patel alluded to this, the hyposmia, or loss of senses of smell and taste, are symptoms, are non-motor symptoms of Parkinson's that occur even in the early stages of Parkinson's, or even in the so-called pre-motor stage of Parkinson's. And in fact, loss of sense of smell may predate the diagnosis of Parkinson's by as much as 20 years. So even before your tremor comes out, and you have a shuffling gait, and you have slowness of movements, and you become poker face, and you develop a very obvious tremor, these are the so-called motor symptoms. Many patients have the non-motor symptoms, including the REM behavior disorder and this poor sense of smell. And the more of these non-motor symptoms that you present with, whether it be REM behavior disorder, a loss of sense of smell, and constipation, and other non-motor symptoms, then the higher the chances that you are probably in the earliest pre-motor or non-motor stage of Parkinson's. But you cannot use sense of smell as a reliable gauge as to whether you have contracted COVID or not if you have Parkinson's. Now, what has been reported more frequently, though, is that in patients with Parkinson's, they notice a sudden worsening of their symptoms, both motor and non-motor symptoms. And this may be a worsening of motor and non-motor symptoms that they had in the past, or they develop de novo, brand new symptoms. So what kind of motor symptoms can worsen in Parkinson's that can be a telltale sign that the patient has developed COVID even before the diagnosis is made? So very commonly, they get weaker, they get slower, they have more tremors. A big one is falls. I've had many patients that contracted COVID and said that they had increased falls or more imbalance. And then patients with more advanced disease that have a history of dyskinesias tell me also that their dyskinesias are worse. And then for those that have motor fluctuation, which means they have the ups and downs, they switch on for a few hours and they switch off after that, this so-called motor fluctuations, their off time becomes more pronounced or more severe or more prolonged. And also many patients develop increased stiffness or rigidness of their muscles. And then some patients also have difficulty swallowing or increased difficulty swallowing, or even salivation or drooling when they contract COVID. And then many patients also, in fact, even more commonly than motor symptoms, many patients develop worsening of their non-motor symptoms. So they get anxious, they get depressed, or they have underlying anxiety and depression, and these symptoms tend to worsen. They get more confused, and this is a common one, especially my elderly patients, especially my patients that already have some cognitive issues or dementia. They just really get more confused. They get mentally fuzzy. If they have preceding hallucinations from their medicines, they hallucinate big time when they contract COVID. And then many of my patients get very sleepy during the day. They're dream acting, the so-called REM behavior disorder, which Dr. Patel had discussed earlier on extensively and elegantly. This can also worsen in your patients, in the patient with Parkinson's that develop COVID. And then patients with urinary issues get an increase in their symptoms, especially incontinence. Those that are constipated get more constipated, and fatigue is a big one. And then patients commonly describe orthostatic hypotension or dizziness. So when they stand up, their blood pressure tends to drop and they get dizzy, and some of these patients pass out. So that can be a non-motor symptom that tells you or us that maybe you have developed COVID. Okay, what about the vaccine? If I have Parkinson's disease, do you recommend that I get vaccinated? I have three answers for you for this. It's yes, it's absolutely yes, and definitely yes. So it's a yes, yes, and yes. No ifs, ands, or buts about this one. The risk of a fatal outcome from COVID is around 30% greater if you have Parkinson's disease. And therefore, given that the risks are not negligible, 30% is 30%. That's 1/3 of patients dying from Parkinson's. I mean, from COVID. If you have Parkinson's, especially if you have 9 or more years of Parkinson's. So I would really highly advise you to get vaccinated if you have Parkinson's. Especially nowadays, it's really so easy in the United States to get vaccinated with the plethora of vaccines which are available now in the market. Do I expect different or more side effects from the COVID vaccine, given I have Parkinson's? Before the vaccines were rolled out for the general population, initially we had this reservation about sending our sicker patients, our elderly patients, our patients with a history of pneumonia, our patients that are more feeble, our patients who were demented, and we were kind of leery about sending these patients for vaccination and fearful of what the side effects would be. The general observation has been among myself and my colleagues that treat a lot of Parkinson's patients is that it is the opposite. Many of our Parkinson's patients, especially the elderly ones, had almost no side effects from the COVID vaccine. So whereas, like for instance, in my office, and I've got a lot of young staff members and almost university, almost all of them developed some flu-like symptoms, a sore arm, maybe a mild fever, achiness of the muscles. Whereas I would say I hear about those symptoms in my Parkinson's population, let's say 20% of the time. But it's definitely surprisingly much less common as we would have expected in this population of patients. Are there any contraindications for receiving the COVID vaccine if I have Parkinson's? And the answer is also no. So there's no contraindications unless you have, some ongoing infection, you have a pneumonia to start with, or you have an allergic reaction, a severe allergic reaction, to other vaccines. But I would encourage you to talk to your primary care doctor, talk to your neurologist, and see whether there are any absolute contraindications for receiving the COVID vaccine. But if not, if it's just relative contraindications, simply because you're elderly, simply because you have a history of cancer or a history of dementia or whatnot, I would think that it's more of an exception to the rule that a patient with Parkinson's will not be able to receive the vaccine. Okay, is one vaccine preferable to the other to have Parkinson's? The answer is no. So there's no studies that show that one vaccine is safer than others for the Parkinson's population. The best vaccine is the one in your arm, so get vaccinated. Once I receive the vaccine, can I ditch the mask? Okay, so this is a controversial one, especially so in the U.S. That we recently got new CDC guidelines on those that are vaccinated and about their ability now to not use the mask, especially in public spaces or open spaces. But use your good judgment. So if you're in crowds, you're in a closed vehicle, in a public transportation, taking a flight in an airport, just use your good clinical judgment. Just remember, even if you're vaccinated, you can still contract the disease. And so just be careful. Okay. This is an interesting one. Can COVID-19 predispose to developing Parkinson's disease? So we're now talking about you don't have a history of Parkinson's disease. You don't have a family history of Parkinson's disease. If you contract COVID-19, can you develop Parkinson's disease, either acutely or down the road? So I was able to comb the literature and found at least 3 case reports of acute Parkinsonism. And when you say acute, we're talking about a few days or a few weeks maybe, which puts in a subacute range of development of Parkinsonian symptoms, so whether it be a tremor or rigid muscles or slowness or imbalance or a combination of those. So 3 case reports of acute Parkinsonism developing in younger individuals within 2 to 5 weeks of contracting COVID-19. And here's the interesting about this individuals is that if you do a dopamine scan or a DAT scan, which we now use as a tool for confirming or helping confirm, I should say, helping confirm Parkinson's disease, the DAT scan can be abnormal in COVID-related Parkinson's disease. And that, interestingly, of these 3 individuals, two of the 3 improved with Parkinson's medications. Now, for somebody though that has that contracted COVID-19, are you at greater risk for developing Parkinson's disease down the road? Meaning not in the acute stage, not in the subacute stage, but when you've fully recovered and then years and years after you got a little older, are you going to be more prone to developing Parkinson's disease? And the answer is we don't know, but given that similarity between COVID-19 and the Spanish flu and the Spanish flu pandemic, which happened in the early 20th century, many of those patients with this, that suffered the Spanish flu did not develop Parkinson's symptoms or Parkinsonism symptoms in the acute stage, but many of them developed Parkinsonism years after, even decades after. And in fact, if you look at the graph of the number of Parkinson's patients that were diagnosed globally, where the pandemic from the early 20th century, where many individuals were affected. If you look at the graph of the number of Parkinson's patients, there was a huge surge of Parkinson's patients diagnosed years after that pandemic, and that persisted for decades. And in fact, there was some controversial opinion in the past that once this initial surge of Parkinson's patients, once that initial cohort of Parkinson's patients that were exposed to the Spanish flu virus from the 1918 pandemic, that eventually the Parkinson's was going to be a very rare disease, which really hasn't happened. But I would have to say that given the similarity between the Spanish flu virus and the COVID-19, and given now the reports of Parkinsonism, acute Parkinsonism developing in young individuals who contracted COVID-19, I think there is a good chance that maybe there might be increased incidence or frequency of Parkinson's disease over the next few years, if not few decades, moving forward. Okay, this is a frequently asked question, which again, we've not been able to answer in the previous webinars. Does exercise help in slowing the progression of Parkinson's disease? Are there any specific programs that have been found to be more helpful than others? And I always say that to my patients that although we have a long list of good Parkinson's medications now in the market, and that these medicines have been proven to be very effective, especially if they're used in the right kind of patients. I always tell patients that I would estimate that about 30 to 50% of the improvement or sustaining of the improvement of their symptoms from Parkinson's comes from exercise. And what kind of exercise is effective for Parkinson's patients? So it needs to be aerobic. So I usually quote the rule of 20. So your exercise has to increase your heart rate by 20, increase your blood pressure by 20, and you have to do at least 20 minutes per day. So a leisurely walk in the park, or walking your dog in a very slow pace, or walking to the mailbox and back to your house, or doing a little bit of house chores. If these activities are not aerobic, then they're not really that effective. So the most effective exercises for Parkinson's patients are brisk walking, swimming, doing the treadmill, stationary bicycle, boxing, Although obviously, if your balance is very poor, then this is probably not something that you should be doing. Dancing, light weights and stretches. So anything that's aerobic and sustained is good for Parkinson's patients. So not only does exercise relieve the motor symptoms we need, it relieves the slowness, makes you quicker, makes you more agile, makes the muscles less rigid and less stiff, increase the range of motion, improves your balance, makes you more coordinated. But it also improves the non-motor symptoms. So if you exercise regularly, you're just more cheerful, you're just happier, you sleep better. You have less muscle aches, especially during sleep. There's also less restless legs at night, or even during the day among my patients that exercise regularly. And there's also less fatigue. And then there's also some evidence, or should I say strong evidence, that exercise may be neuroprotective, which means it protects the brain cells from dying or degenerating further. So the question is, if I am at risk for Parkinson's, so I have a family history of it, I now have the non-motor symptoms, I have REM behavior disorder, I may or may not have had the skin biopsy yet, looking for alpha-synuclein. Can I delay the appearance of the Parkinson's motor symptoms if I exercise vigorously? Or if I already have early Parkinson's, my DAT scan is positive, I have a little bit of a tremor, I have a little bit of shifting or a little bit of slowness or a little bit of poker face, or my arm swing is poor in one side. In other words, I have early signs of Parkinson's. If I exercise vigorously, will that delay the progression of the disease? So these are great questions that everybody wants answered, obviously. And the answer is yes. Exercise can be neuroprotective. And how does it do that? It does that by fostering the production of what's called healing factors or neurotrophic factors. These are healing factors. So it also not only does it help, with the local effects on your muscles and your joints and your ligaments and all that, but it also increases blood flow. It also has an anti-inflammatory effect. And then finally, it fosters the release of anti-pain chemicals, so-called endorphins. And then one patient of mine asked me, is it possible to do too much exercising? I guess one of the caveats we go by whenever we try to achieve something, especially exercising or reaching a goal, is no pain, no gain, right? But in my Parkinson's patients, if it starts to hurt, it's probably too much. And so just do the aerobic, exercises and do as much of it as you can tolerate. 20 minutes is a good goal. I have some patients that obviously do more than that. If you walk, a mile or two per day, that's great, especially if you get your heart rate up and your blood pressure up. But I have one patient that walks about 40 to 50 miles per week, and I said, "Wow, that's a whopping number." But you don't have to overdo it to get enough exercise and for the exercise to be effective. Okay, I've had a number of patients that asked me about light therapy, and initially I didn't know anything about it until I read a recent trial on it, which was a phase 2 trial, which was performed in the US and the Netherlands. And this was a study on 92 Parkinson's patients on medications. And they used phototherapy or light therapy, and this was compared to placebo. And they received this 1 hour each evening for about 6 months. So the device that they used was called the Photopharmic Celeste phototherapy device. So this was not an ordinary lamp. So this was a light or lamp that combines different light intensities and bandwidths. And the principle behind this was light regulates the circadian rhythm, which is acknowledgedly abnormal in Parkinson's patients, which is why many of our Parkinson's patients have poor sleep or sometimes have even sleep reversal. You have an internal clock in your brain that regulates the circadian rhythm or the wakefulness and sleeping rhythm. So what they found out was that phototherapy or light therapy improved the severity of both the motor and non-motor symptoms. So there's a larger ongoing phase 3 trial using the Celeste Light for Parkinson's, which aims to enroll about 200 Parkinson's patients in the US and the Netherlands. So if you hear about this, don't be surprised about how this can potentially help Parkinson's patients. Okay, what about music? And there is an ongoing trial for music therapy. And usually when we talk about music, we talk about singing. So this has nothing to do with the big and loud. It has nothing to do with projecting your voice and making it more audible. This has to do with gait. Music therapy and gait, especially freezing of gait. So there's this clinical trial called the MedRhythms clinical trial. This device, which you see here in the right side, so you have a set of earphones, and then you've got a device that plays the music, and then there's a sensor in your shoe, and then as you walk, it kind of detects your pattern of walking, and then introduces a certain music that will make you walk better. So it couples or coordinates or entrains what you hear with how you move. And so this is a trial that's ongoing for Parkinson's patients. In fact, for my patient with freezing of gait, one of the things that I make them do, one of the tricks to then freeze them, is to make them get into a rhythm, whether it be rocking or counting or even singing a tune. And many of these patients get unfrozen. So this is something that's being done now in a trial, and hopefully will be a device that one can wear in the future to help with therapy. And here's somebody with significant gait difficulty, Parkinson's patient. I'm going to fast forward. So he has difficulty walking. He uses a walker, takes little baby steps, and then he freezes right there. You see his feet are frozen. And this is typical for patients with Parkinson's and freezing that go through doorways or narrow hallways, or when they turn, when they pivot. So the freezing is something that occurs. And then he's made to listen to music. So now the music is played. So he's getting his rhythm now. He's kind of rocking his head to the music. And suddenly he's able to unfreeze himself. He's suddenly able to walk more effectively. So in effect, the music is entraining his motor movements. He's literally walking in sync with the music. So it's really phenomenal when you see something like this and see how effective this thing is. So this is one of the tricks for freezing of gait for Parkinson's patients, which again is being explored in that trial that I just talked to you about in the previous slide. So music therapy for Parkinson's, very interesting. Okay, what about cognitive issues in Parkinson's? Very common. Although the good news is that dementia in Parkinson's is a late feature. So in fact, when we see patients with significant cognitive issues and they're demented from the get-go and they're hallucinating and they have delusions, I kind of question whether it's truly Parkinson's or not. In fact, there's a crossbreed between Parkinson's and dementia called, or Alzheimer's disease called dementia with Lewy bodies. And the only drug so far that is approved for Parkinson's dementia is Exelon, which is rivastigmine. But there are no drugs approved for MCI, which is the precursor. So MCI refers to mild cognitive impairments. Obviously, you don't go from elderly, just a normal elderly forgetfulness to dementia, just like that. You go through a middle phase called mild cognitive impairment, which should last for several years. And there's no drug for that. And So there's an ongoing study, and including here in Arizona, on Aptinex, a drug called NYX458. So it's just a code name for now, but this is being now explored specifically for MCI and mild dementia and Parkinson's. And also they recently opened this study to patients with mild dementia with Lewy bodies. So the way this drug works is that, or I should say, the principle behind it is that dopamine regulates the so-called NMDA receptors. So NMDA receptors are essential for nerve-to-nerve communication. So that lack of dopamine causes this poor nerve-to-nerve communication in your brain, neuron-to-neuron communication, therefore leads to cognitive decline. So if you give something that regulates the NMDA receptors, which is what this drug is all about, then they're thinking that this could improve MCI or mild cognitive impairment or even dementia in Parkinson's patients. So be on the lookout for this, for advertisements in wherever you are, including here in Arizona, because this is a good study to participate in. Okay. I've had many patients that do Tai Chi for Parkinson's. It's great for balance. In fact, there's many studies that have shown that Tai Chi is a great exercise for patients with imbalance, aside from yoga for my Parkinson's patient. But I found this interesting study on golf versus Tai Chi. So which one is better for Parkinson's patients? So this was a study done at Harvard, the Massachusetts General Hospital. There were 20 Parkinson's patients with moderate Parkinson's. And then they were given 10 weeks of 1 hour twice weekly classes, and you either attend a class for golf, aside with the golf cohort, or you attend a class for Tai Chi during those 10 weeks. So 8 patients were assigned to golf and 12 patients were assigned to Tai Chi. And then what they tried to measure was this thing called the time up and go test. So what they do is they make you get up from a chair, they make you walk 10 feet as quickly as you could, turn around, and then go back to your chair and sit, and they timed that. So which one did better? Was it golf or was it Tai Chi for Parkinson's patients? So what they found was that golfers had an improvement by 0.96 seconds in that time up and go test, whereas Tai Chiers had a worsening by 0.33 seconds in their time up to go test. So I guess Tai Chi is great for balance, but when it comes to speed, I think the golfers will win. I'm not aware of any study though that shows that golf is good for balance. But I know for a fact that Tai Chi is, aside from yoga, as I mentioned, is very good for patients with imbalance and Parkinson's. But if speed is the issue, I guess golfing will benefit you better than Tai Chi. Okay. I found this interesting slide. I thought it was very appropriate even for my Parkinson's patients. Many of my Parkinson's patients ask me whether what they eat influences their Parkinson's, or the risk for Parkinson's, or influences their Parkinson's symptoms. So I've spoken about the Mediterranean diet in my previous talks on its benefits, not only for your risk for Parkinson's, but for your risk for Alzheimer's disease. There's this recent study, a Japanese study out of Osaka University about sesame oil and its waste product called sesaminol. So what they did was they treated mice with, first they fed mice with rotenone. So rotenone is it's rat poison. So it's a pesticide, and so rotenone is one of our pesticide exposure will be one of the risk factors for developing Parkinson's. So you can induce Parkinson's by introducing rotenone. So but if you introduce sesaminol along with the rotenone, what they saw in this studies was that there was less loss of dopamine neurons and less accumulation of this bad thing called the Lewy body, which we see in Parkinson's brains. And also they found out also in that mice study that the mice that were made to develop Parkinson's through rotenone had better movements and balance and less constipation, which is a non-motor symptom. So sesame oil. I'm not sure how many of you guys love sesame oil, but I do love sesame oil for my salad. But This study I found very interesting, which showed that maybe it has some antioxidant properties and can protect the brains of patients that are at risk for developing Parkinson's. And then lastly, I think this will be the last slide given the time constraints. Many patients also ask me about natural sources of L-DOPA or levodopa. And in my previous talks, I talked about mucuna pruriens. I also talked about fava beans, which are natural rich sources of levodopa or L-DOPA. But I also found out recently about another natural source called berberine. So this is a natural plant compound which has been used in China for many, many years. It's an over-the-counter remedy for diarrhea. And they found out that if you give berberine for diarrhea, it actually increases the amount of L-DOPA or levodopa in the blood and in the stools. And the way this works is that it enhances an enzyme called tyrosine hydrolase. So to make something complicated very simple, you need this enzyme called tyrosine hydrolase to produce L-DOPA from an amino acid called tyrosine, and you need the gut bacteria for that conversion. So berberine is a natural source, in effect, of L-DOPA in patients who want alternative sources of L-DOPA and do not want, a drug, an artificial drug. So I think that's all the time we have for questions. I'll try to answer more questions in the next webinar. I want to thank again Dr. Patel for the excellent lecture and discussion. And then please feel free to send more questions to us, which we can again answer in the next webinar, which I think will be happening sometime in August. So at this point, I want to thank everyone.